अभी अपना माइक चेक कर लिया बस।
Dr. Sharik, good evening. Assalamu alaikum. Can you hear me, Dr. Sharik? Hello.
Assalamualaikum.
Walaikum assalam. Dr. Sharik, how are you doing?
I'm fine, alhamdulillah.
All right. So today I was thinking that as this meeting is now progressing towards its ninth time we are meeting together for case discussion. So if it is possible for you, can you moderate today's session?
Okay. Thank you very much. I will moderate.
All right, Dr. Sharik. Then there are 3 cases, and 2 of the cases are from Liaquat National Hospital, and 1 is from your institute. And today we are very that again we have Professor Dr. Sardar Tegul with us, and we'll shortly be starting our case discussion. So I wish you good luck for moderation of today's meeting.
Thank you. Okay, we are starting in 3 minutes. We will start with Dr. Idris' case first.
Okay, sir, I'm ready.
Okay, Dr. Idris, we will start in 3 minutes. 2 to 3 minutes we will start, okay?
Okay, sir.
Assalamu alaikum. I will like to thank Dr. Sardar Tejgul for joining our meeting, and we will start with our first case with Dr. Idris. And Dr. Idris, you can start the first case.
Okay, sir. Thank you for inviting me into this meeting, sir. Sir, first of all, Assalamu alaikum and good evening, everyone. I am going to present a case. Okay, starting with the history, our patient 5-year-old child, weight 13 kg, resident of Karachi, referred from Patel Hospital, Karachi with complaint of lower urinary tract symptoms since birth and raised creatinine. According to the parents, patient had a long-standing complaint of poor urinary stream, associated complaint of increased urinary frequency with urgency and urge incontinence. No history of fever, hematuria, constipation, and passage of urethral stones. Coming towards the past history, the in medical history, no history of prior hospitalizations, no diabetes, no hypertension, no history of respiratory complaints. His surgical history and family history insignificant. Patient and birth history, normal vaginal delivery and postnatal history is insignificant. Patient development history all within normal milestones. Immunization according to the EPI schedule and BCG scar was present also. On social history, the teachers complain in schools that the patient doesn't go for the voiding. Coming towards the examination, the patient was active, alert child with the following vitals. All the vitals were within normal limit. His abdominal examination and the relevant examinations were all within normal. Uh, on examination of the examination of the back, no obvious anomaly. Coming to the patient presentation, which was raised creatinine within as we can see the investigation in this table, the CBC and the electrolytes and urine CS all were normal, but the patient has raised creatinine since 1 month. And on the 1st March of 2022, it was 2.8 and it has raised to 3.7. It was the time when the patient presented to us. So the ultrasound was done from the outside, was from the Patel Hospital, which was done, and it showed that bilateral kidney has severe hydronephrosis and hydroureter with CMD poor. The urinary bladder thick walled with 0.9 centimeter. The patient admitted under the PEDS nephro for the CKD secondary to PUV, bilateral VUR, or neurogenic bladder. PEDS urology opinion was requested for further management. So the PEDS urology had requested and done the X-ray MCUG on the 11th April 2022. The findings, as we can see in the diagram, that bilateral vascular reflex grade 5 on the left side and grade 3 on the right side. Posterior urethral wall appears to be dilated and elongated. The bladder shows trabeculation, sacules, and diverticulum of lower capacity with low capacity. So the patient was then planned for the cystoscopy and PUV resection. The patient was operated on 14 April 2022. The findings during the operation was severe trabeculated bladder with multiple diverticulum and sacules. Thick-walled PUV resection was done at the 5, 7, and 12 o'clock. A small capacity bladder with only 20 to 30 ml, and post-void was it was a good stream. So initially, after the operation, the creatinine came to 1.5. When the patient presented to us, it was 3.7, and after operation, it came to 1.5, and his lower urinary tract symptoms were improved. But after few follow-ups, the creatinine has raised to 3.4 into 8.2 within 3 to 4 months. This 8.2 was in August 6th August 2022. So the patient had then started hemodialysis from the SIT via right IJ, and the total number of sessions were for last hemodialysis was done on 12 September 2022. Patient then had a left BC brachiocephalic fistula made from the SIT last month. Again, the MCG was repeated after 5 months on 15th September 2022. The MCG shows very improved results with mild trabeculation and sacules with good urinary bladder wall. Bilateral VU reflex was not seen. Posterior urethral wall was not dilated, and anterior urethra was normal. Residual urine not seen on the post-void volume. So, as the patient has already been diagnosed with the ESRD secondary to the PV, so the patient is planned for the right renal transplant, or left renal transplant. The main query is how to proceed for the bladder. Should we go for just cystoscopy and then look into the bladder and plan for augmentation and cystoplasty, or should we go for the urethral reimplant? So it is the main purpose of this case was to find out how to proceed in this patient.
Thank you, Dr. Idris, for the presentation. I will like
Thank you, sir. Yes, sir.
I will like to summarize this case. Basically, this is the case of a child of, I think, 4 to 5 years, and what happened in this case was the patient presented originally the creatinine raised to around 5 before we did the valve resection preoperatively, and the CS was positive. It was treated by multidisciplinary approach. Combined peds, nephro, and urology team have managed the case, and after the valve resection, the creatinine come down to around 1.2 or 1.5, and the patient was discharged. And on the frequent peds nephrology follow-up, it was seen that in just in the span of 5 to 7 months, the creatinine got up to around 5 to 8, and patient was referred for to another institute for hemodialysis and for transplant workup. In between, we didn't see the case. Recently, they just the place where the transplant was going to happen, they did the MCUG. The MCUG was quite better. Significant improvement was seen from the previous and this one. What we want to ask is there anything that can be done differently so to improve so that the prognosis of the child would have been better? So if what differently should be done in this case so that this child should not end up in CKD in the span of 6 months?
Dr. Sharik, thank you so much. Dr. Shah, I have a question that before going to any new development in this child, whether you like to go for the urodynamic study or not?
Yes, because the urodynamic will be done, cystoscopy, and all those things, this will be planned. Because if you are going for transplant, urodynamic and cystoscopy, everything, shorter workup should be done before transplant. But this child, what is CKD now, and they are planning for transplant workup. What our query is, what should be done differently to avoid this CKD? Now the patient is CKD. What differently should we have done, or any plan that should be done that we have missed, that the patient should have avoid going for transplant, and the patient just end up on dialysis in just span of 6 months, rapid progression of disease. I have seen very few cases that have been rapided so quickly into CKD. But the issue with them, most of them, was that their MCUG or their bladder was very bad. But there is an improvement in MCUG. The bladder is voiding well. Previously, he was not able to void. The grade 5 UR just was resolved. The bladder got little bit more smoother, and patient was voiding well.
Dr. Sharik, I have one point on your case, because the case that you presented is very, very important for any pediatric urologist to learn. Plus, your questions actually show how much you got worried when you see improvement in the MCUG, but no improvement in the outcome of the patient. The patient proceeded to the to renal transplant. Now he's on list for renal transplant. So what I feel, your question is valid, and the query that is raised in your mind, it can be, can be answered with a very simple question: that if you had given this bladder a chance to remain on a suprapubic drainage post PUE ablation, I think we could have avoided the blow up of upper tracts that was resulted because the child was left with his native bladder, which was already a very high pressure bladder. That resulted in the bad outcome that we are seeing there. But yes, there could be other points from the panelists. But my point was that when you ablated the well, at that time you could have provided some outlet for this patient.
I think there was a valid point. We were thinking about this at the time when the when the patient was, when we are going for the valve ablation, that we should either put a suprapubic if we found that there was a chance of having a neurogenic bladder in the future. But family was was not very much toward the suprapubic. They say if something happens, then you can go for suprapubic. Otherwise, you should give a chance. Then they were agreeing for going for the second procedure to go for suprapubic. That's why we avoided. Otherwise, we have put it just to be sure.
Yes, because this is very commonly seen in Pakistan, that it is up to the attendants if they want to avoid suprapubic, which usually they do avoid. Then the case becomes. But did you follow him between May and August? Like,
No,
what was
the child just came to me after 6 months. Issue was that after valve resection, the patient creatinine just dropped from 5 to 1.1, and the child doesn't came to my clinic for around 6 months. His father just came.
From Dr. Shah, he's Dr. Sardar.
Yes, my question is how the child's general condition changed after the valve resection. Did he get really better generally, and did he gain a lot of weight after the valve resection?
No, sir. After valve resection, the creatinine improved, the patient voiding improved, the patient was discharged. Follow up after 1 week, the patient was generally better. After that,
yeah, but what usually happens in those children is the valve resection helps the kid a lot, and the general condition of the patient improves dramatically. And most often they put a lot of weight on, and since the kidneys the residual renal function is very low, when they put a lot of weight on, the marginal kidney function goes into the other side, and it becomes a chronic kidney renal failure. And I wonder if that was the case. I mean, if he had gained a lot of weight in between the valve resection and the time of dialysis within this 6 months, this could be one explanation of the creatinine increase.
No, he doesn't gain too much weight. I think there was increase in 4 to 5 kg of in 6 months. But currently he's now after he have developed CKD. He's on dialysis again. The weight have dropped, but he will gain around 3 to 4 kgs. And but the issue was that the patient got lost to follow up, and when he
I
came to us,
see.
when he came to us, he was already CKD.
Well, I mean, you need to see that this patient had already had marginal kidney function. Then it was the creatinine was about 3 plus, right? 3
Yes,
point
it was
something.
when he
This
presented.
was
It was
already
five,
this
five.
was already in chronic renal disease status, and shortly after resection, it improved a little bit. That doesn't mean that he improved completely. So it's no surprise that this child could easily go to the renal failure. So I don't know if, I mean, even if he had done something like putting a suprapubic tube or intermittent cath, this child would eventually go to kidney failure anyway, either within 6 months or later, because the kidney was already at the marginal function and the residual renal function was not good enough to go for more years. So I think one issue now is to consider what we're going to do before renal transplant. And of course, this bladder should be well evaluated with urodynamic studies, and we need to know the bladder capacity and the pressure at the capacity, and that will tell us whether we need to do an augment or not. And if we need an augment, I think doing a ureteric augment, ureterocystoplasty, could be a good choice. Remove one kidney and use the dilated ureter to augment the bladder.
Dr. Sadar, the presenter was asking if this morbidity could have been avoided.
Well, yeah, I know. I got the question. I don't think I don't think that even if he had done something like doing CIC or putting a suprapubic tube, this child would eventually go into renal failure because the kidney function was already very marginal. That's what I'm saying. And I don't know if we could have avoided. Maybe we could have lengthened the time to the kidney failure, but not necessarily stop it.
Okay.
Thank you, Dr. Sardar. Thank you.
Thank you, Dr. Sardar. One question from me. Dr. Sardar, what I got from your point that basically these kidneys are dysplastic since birth. That's why they eventually go into the failure anyhow after PU resection, isn't it?
Yes, I mean, not only they are dysplastic, but this is also a late diagnosis. The diagnosis was made at the age of 5, and there's already been quite an amount of kidney damage. So, I mean, there's not much you can do with those kidneys. If you'd been able to do the valve resection much earlier in the first 3 months of life, you could have avoided some of the, I mean, you could have saved some of the kidney function and then actually avoid renal failure. But at the age of 5, this is a very late diagnosis. Both kidneys are refluxing. And if only one kidney was refluxing and the other kidney was not refluxing, the pop-off mechanism would prevent that, save that kidney that's not refluxing. This could have been a good opportunity for that kidney to keep some of its function. But even in that case, I mean, late diagnosis, both kidneys are refluxing, it's already a lost gain.
Thank you so much. Thank you.
Thank you, Dr. Sardar. Thank you. Now we will have our second case. The second case will be presented by from Liaquat National. Dr. Noor will present it. Dr. Noor, you are with us?
Yes, Assalamualaikum everyone.
Okay, Dr. Noor, you can go ahead.
What's happening? Okay, I'm having some trouble sharing my screen. Uh, can we proceed to the next presentation while I figure out how to share my presentation with you all?
Dr. Sharik, can you ask the other presenter? Dr. Sharik?
Is my screen visible to all of you?
No.
Okay. Okay, so you proceed to the other presentation while I figure out.
Okay,
how
Dr.
to-
Akash, can you go ahead with your presentation?
Hello. Yes.
Okay, Dr. Akash, you can go ahead. Dr. Akash is from Lekha National. The case is from Lekha National. And Dr. Akhtar, it's your case now.
Okay. Assalamualaikum everyone. I'm Dr. Akash Mulani from Lekha National Hospital. I will present a case. Eva next. A 4-year-old male child passed diagnosis of PUV plus bilateral VUR plus renal failure plus urosepsis. The past surgical history patient has a bilateral urostomy in 2018 and fulguration of valve in 2019. The aim of presentation to discuss the future plan because the patient has a solitary function right kidney with moderate hydronephrosis and scarring on DMSA with compromised renal function. Next. According to parents, child was born via SVD at home and cried immediately and passed meconium. His third antenatal scan shows bilateral hydronephrosis with palpable dilator bladder. According to mothers, the child at the 50 days of life, he came OPD with complaint of abdominal distension and decreased urinary output for 3 weeks. His workup at LNH revealed bilateral grossly enlarged kidney with severe hydronephrosis and hydroureter with thick walled partially filled bladder. With creatinine is 1.57 in 2018 and urea is 140 and BUN is 65. With the episode of UTI, the urine CS grew candida albicans and creatinine was raised to 2.4 and with a bladder drainage and antifungal and the broad spectrum antibiotic reversed to started and reversed to 1.1 grams creatinine. His MCUG showed a regular small bladder with grade 5 VUR and PUV. On post-maturation film, the residual contrast is hugely dilated, show dilated ureter, which seen therefore bilateral ureterostomy were made on 23/9/2018 and his creatinine dropped down to 0.5 mg per deciliter. Next. On DMSA, which was done on 17/11/2009, showed fair function of right kidney with poor functioning of left kidney. His voiding history suggested he was void in the form of intermittent stream with straining and
Slide.
hello.
Can't see your slides moving.
Okay, ma'am. On examination, patient vitally stables, and abdomen was soft, non-tender, bilateral urostomy was seen, and patient was circumcised and bilateral descendant testes. Other examination are unremarkable. His past investigation at the 50 days of life, patient's CBCs was showed normal and UCs was showed grade 2.4, which are highly increased, and urine DR was showed pH pH 6, protein 25, and RBCs 15 to 11, and grew east, and urine CSO candida albicans. And ultrasound KUB at the time of presentation, both kidney appear enlarged and severely hydronephrotic with epidiameter and renal pelvis is a 4 centimeter, moderate to severe hydroureter seen. Right kidney approx 10.5 centimeter and left kidney approx 10.5 centimeter. Next. This is a UC strand which showed from 2018 to 2022, which showed the creatine level which severely first is increased and then showed in a decline pattern. And creatine in 2018 shows 1.9, and then again repeated 5 to 6 months, which showed 1.5, and after bilateral urostenomy made, then creatine which showed 0.8, and so on. And 2020 creatinine which showed 0.8, and 2021 which show creatinine 1.0. Next, Shiba. This shows ultrasound trends which show multiple ultrasound of these patients. The ultrasound of right kidney in 2018 ultrasound KB was done, which showed right kidney enlarged, moderate hydronephrosis, and left kidney is small and with increased echogenicity. A grade 2 parenchymal changes seen in left kidney. In the ultrasound KUB 2019, which was showed both kidney measures 5.8 centimeter and left kidney showed 4.8. Both kidney are echogenic in texture and bilateral hydronephrosis and hydroureter seen. And 2019 ultrasound KB was done, which showed right kidney is 6.1 centimeter and left kidney which show 6.8. Right kidney show mild hydronephrosis and left kidney which showed increased parenchymal echogenicity with corticomedullary distension and grade 1 to 2 parenchymal changes showed. Next. And again ultrasound KB in 2020 which showed right kidney is 6.6 centimeter and left kidney 6.0. Right kidney shows renal
Akash,
moderate.
Tell us only
Hello.
about 20 ultrasound report.
Yes, ma'am. Sorry, ma'am.
Can you please tell us the recent ultrasound?
Yes, ma'am. Next. The recent ultrasound was done in August 2022, which showed right kidney has a normal size 8.2 centimeter and moderate to severe hydronephrosis, hydroureter seen in right side, and marked thinning of cortex also seen in right kidney. And left kidney shows small in size 5.2 centimeter with mild hydronephrosis and hydroureter on left sided. And bilateral vesical ureter effects also seen. The DMSA scan was done first on 2018.
First shows the first and the recent one.
Okay. Okay. First was DMSA done on 2018, which showed right kidney function is 80% and left kidney is 18%. Fair functioning of right kidney with scarring and poor functioning of left kidney. Next. And the recent one DMSA scan was done on September 3rd, which showed right kidney function was 79% and left kidney shows 25%, 21%. And the fair functioning of grossly hydronephrotic right kidney with possible scarring over upper and lower pole of the kidney and small sized and reduced functioning of left kidney. Next. His MCUG was done on 2018, which showed the bladder outline appear thick, weld with short trabeculated margin. The reflects the marked dilatation of pelycalyceal system with blunting of furnaces and dilated and tortuous ureter on either side.
Okay,
and
on this film, I will request Dr. Akash, please go back, because this
Yes,
is a
ma'am.
very important image in understanding this case. In 2018, when the child was 50 days of life and he presented to us, this MCUG was carried out. if you see in the first film, as soon as the bladder was filled with the contrast, the left side after the bladder was filled, the left side started filling, and it filled very, very dilated upper tracts, like first it filled the left ureter, then it started filling the right ureter, and more contrast going into the upper tract. And when the child voided, um, his bladder seemed to be irregular, and he voided. And when he voided completely, as we can see in the post-void film, the upper tract still had very much contrast. Even after 15 minutes, this post-void film was taken after 15 minutes, still you can see the contrast in the very dilated ureters. And the ureters were more enlarged than the side, were as much in caliber as the bladder was when it was filled. So we can see how much the upper tracts were dilated, they were obstructed, and they were refluxive also. Please proceed.
Yes, ma'am. The past surgical history was bilateral ureterostomy plus PBS done in 2018, and then EUAI done on 2018. The cystoscopic plus PUE fulguration in 2019. And then again, we repeat the cystoscopy, which showed no residual vein in 2020.
Okay, so
Eva, what is the
I will take this opportunity to summarize this case. So now this child is a 4-year-old male child who presented to us when he was 50 days of life. He came with an antenatal diagnosis of bilateral hydroureteronephrosis and a distended bladder. And when he presented to us, he was in severe sepsis. His blood culture grew candida, his urine culture grew candida, his creatinine was on the higher side. And we provided him with drainage via putting a catheter. And when the infection subsided, we got a MCUG that I just described. And his creatinine dropped down to 1.7 with these maneuvers, with treatment via drainage and antibiotic antifungal. Then when we saw this MCUG, where even after emptying of the bladder and waiting for 15-20 minutes, the ureter didn't empty, we made bilateral ureterostomies. Afterwards, the child did not suffer febrile UTIs or any hospital admissions. He started growing, and he suffered a problem of gastroesophageal reflux, and he struggled with that, but that also did not require any surgery, and it became better with when he grew up to age of 2 years, and then he started putting on weight. So now he's 4 years old, he's toilet trained, he's with bilateral ureterostomies, and we know now that his left kidney is poorly functioning, the cortex is thin, and the left ureterostomy in fact does not make any urine. So what should be the plan in this child who was initially saved from urosepsis? Then he remained fine for the last 3.5, almost 4 years now. What should be, how should we go about this case?
Dr. Hina, can I ask about suprapubic? I think in the presentation, the resident showed that the bilateral ureterostomy with suprapubic catheterization was done in 2018. Isn't it?
No. There was no suprapubic catheter.
Okay.
Posterior urethral valves, he's living with bilateral ureterostomies. When I made ureterostomy, there was so much thick pus on both the sides. And even with ureterostomy, it was very difficult for us to empty the entire bladder with the pus, because the pus was very thick and the ureters were not emptying even with ureterostomy. because they were so tortuous, convoluted. There were many kinks within the ureter. I still remember the time taking the ureterostomy. It was even with the ureterostomy, the system was not emptying perfectly because of the convolution and tortuosity and the thick pus, which grew candida later on. The child was so much septic that we had to kept him in ICU, and there was a chance that he had put on ventilator because he was very dull, and his vitals were not stable at the time of admission. So there was only ureterostomy, and there was no suprarenal catheter. So there are many challenges in this case, and one was that when you decide to make ureterostomy, you also decide that one day you will close ureterostomy or decide for reimplantation. And whenever a surgeon makes stoma, he has plan for its reversal or reimplantation in the back of the mind. In this case, he has been saved from infection, recurrent hospital admissions. He had a tough time during the first 2 years because of gastroesophageal reflux disease, for which he had repeatedly chest infections. But then he grew out of it. Now he's a child who is toilet trained and needs definitive treatment. But with this bladder, should we augment and reimplant? Should we reimplant by the right side and augment the bladder from the left side ureter?
Currently the child is fine, and he is now 4 years.
Absolutely.
So we have to do. Why not just do a ureterostomy reversal, suprapubic, and urodynamic, then plan?
Ureterostomy reversal, Dr. Akash, can you go back to the MCUG slides?
Yes,
Dr.
ma'am.
Ureterostomy reversal, because when we did an MCUG, again through this bladder, I would like you to see the images.
Okay, ma'am.
Akash, can you show the
Yes,
slide?
ma'am.
No, go back. Go back.
Go back.
Yes, stop there. So this study was done in 2020 when we decided that we have to do something. Then the corona started. So this shows when the bladder was filled, there was a reflux towards the ureterostomies.
But ma'am, you will plan for reimplant also, so reimplant can resolve this problem of reflux.
Sorry, I didn't get your question.
I'm saying that you are worried about the refluxing ureters in the distal area, but you have a both side of ureterostomy right now. If you will plan to go for reimplant, then you will reimplant the make a tunnel and reimplant. Then the refluxing issue will be resolved. But here the contour of the bladder is good, and I can't comment exactly, but because the slides are very small. But I don't think so. You will face any kind of refluxing again. But yeah, if you have an option for urodynamic out, then assess the bladder after that. But I think this is the right time to reimplant both side of ureters. It's 4 years.
First of all, Dr. Rashid, what I think is if I reimplant only one side, which is the right one, which is better kidney, the ureter is still, even after ureterostomy, the ureter is so much dilated that every time on ultrasound, we see a severely dilated pelvic calyceal system and a very dilated ureter. If you have not noticed, when Akash was presenting, the ultrasound trend showed that every time, even with the ureterostomy, the draining urine, when it is draining urine, even hydroureter has not gone. Um, but that's not an issue with me. The issue is the ureter, even with this dilated ureter, it is very difficult to reimplant it in the bladder. Reimplantation of a dilated ureter is not that easy, especially when the child's renal function is so much borderline and compromised, and then leaving, just doing the reimplantation is not going to solve his problem.
I think I will like Dr. Sardar to give some input on this.
Yeah, my question is, what kind of a ureterotonostomy is this? The loop tonostomy?
Yes.
Loop ureterostomy?
Loop.
Sorry?
Yes.
Is it the loop?
Yes.
So actually, there is no urine going into the bladder, right? So this is a
Yes.
small dry bladder.
Yes.
Okay. What I would suggest is, I mean, initially, why did you do it bilateral? You could have done unilateral, because if you do unilateral loop cutaneostomy, the loop will reflux, then you'll have a refluxing stoma, and also the kidney will drain well, and you keep the bladder cycling. So bladder cycling is important for this patient to keep the bladder good in capacity. Now the bladder capacity is so small, and reimplantation into that bladder would be very difficult. And especially when you divert your valve bladders, there is a risk of creating a small bladder if you do not recycle the bladder. So I would have suggested that you should have done a single site loop cutaneostomy. This would have helped the other kidney anyhow, because of the reflux from that side, the other kidney would be preserved anyway. And then actually what you would do is you could have done an easy reimplant, because the bladder capacity would be much higher than now. And for this bladder, which is quite small, doing a reimplant would be very challenging. And of course, you don't need to do bilateral reimplant. You can do one side reimplant, the right side, and keep the loop cutaneostomy intact and do the reimplant and see how things are improving. So this will help the bladder cycle a little bit. And also, because of the reflux from the left stoma, the bladder will be preserved, the kidney will be preserved. And if you wait long enough, maybe the bladder will get better in time, and then you can take the left kidney out and close the loop cutaneostomy. And if it doesn't get better, then you can do a augmentation using the left ureter.
Okay, Dr. Sardar, if you go.
Can't hear you.
If we think in the retrospect, and you see the first ultrasound.
Can't hear you. It's disconnecting.
Now.
Yes, better now. Yeah.
Can you hear me now?
Yes, I do. Hello.
Hello, Dr. Hina. I think Dr. Hina is having. Ji, now we can hear you.
Okay. Akash, to go to the slide where ultrasound reports were mentioned. Dr. Tegul, if you were to make a ureterostomy, let's suppose if we think in the retrospect, what side would have you made a or suggested to make ureterostomy.
I would have used the bad
Because the
side, the bad kidney side.
child was very sick. As I said, he was in severe sepsis. He was in ICU.
Okay.
And Akash, go
I
to
would,
the ultrasound slide of 2018.
Yes, ma'am.
This
Eva
is
Beck.
2021.
Yes.
well, we know that the left kidney is worse than the other one, right? So I would have used the left ureter as the stoma or the loop tonostomy and see how the patient is
When
improving.
he first presented, it was in your first. Okay, so we have to decide that on ultrasound which side looked bad and to make ureterostomy in that. This was the report of ultrasound when he came. Both kidneys were 10.5 centimeter. Both were severe enlarged. So I think in comparison, we have to decide which side looks more bad and then made ureterostomy in that.
Well, I think you can look at the parenchymal echogenicity. Most often you can differentiate the worst kidney from the other one by just looking at the parenchymal echogenicity on the ultrasound. And the smaller kidney with more echogenicity would be the worst one. And I would use the ctonostomy, I would do the ctonostomy on that side. But because of the king and torsion, with very large ureters, there may not be a very good drainage of the other side. If that is the case, you can do nephrostomy to help the patient to get out of sepsis, and then you can follow the patient with nephrostomy by clamping the nephrostomy and see how that ureter is draining. And that would avoid doing bilateral ureterostomies, and this will help the kidney, the bladder grow in size and not get very small.
Okay. Okay.
And one other issue is if you do bilateral diversion, I would not advise doing valve fulguration because there is a much higher risk of having ureteric stenosis on a dry urethra. And you can do your fulguration later when you start functioning the bladder or cycling the bladder. If you do it on a dry urethra, the risk of having urethral stenosis is higher.
Okay.
Thank you,
All
Dr.
right.
Sardar.
Thank you very much.
Thank you, Dr. Sardar, for your input. Thank you. We have another case, Dr. Noor. Is your system working or not? Still having some issues?
Dr. Ilahi Baksh wanted to say something. He was raising his hand, and we are left with only 10 minutes. I don't think so. We can finish with another case. We can take comments from other participants.
Okay. Dr. Ilahi, do you want to say something?
Hello, Assalamu alaikum.
Yes, Dr. Ilahi.
Assalamu alaikum.
Welcome.
I want to say in this case that you are going to do urodynamic study to see the volume of the bladder and how much it's the capacity. It would be definitely a thick wall bladder. It looks to be as from the first MCUG. So going to reimplant it. Dr. Hina, would you remove the distal stump and bring the proximal dilated tortuous ureter to reimplant? And with reimplant, it also needs augmentation. So, Sir Tegil was asking that we will do augmentation with using the non-functioning side ureter.
Yes. Dr. Ilahi Baksh, the comment was already been made what to do. And we decided that in this patient, though it is very to reimplant a very dilated ureter in a very dry, small volume bladder. But we are going to
Okay.
do that. And yes, I'm going to do the distal part and reimplant the ureterostomy into the bladder. And later on,
Okay.
and for when the reimplantation would take place, the left ureterostomy will stay like it. And then later on, to augment the bladder, the left ureter will be availed to augment the small
Okay.
bladder.
Thank you. Thank you. Probably it was weak English. I could not pick the point.
From now onwards, everyone is going to receive the email regarding the query related to the case, the name of the presenter, and the institute's name, so that and we would like to have panelists with us, so that every case will receive its due attention from the panelist, and a conclusion will be made after the panelists review the case on their own convenience. It will not only save the time, but will also direct the case discussion in a proper direction. What do you think, Dr. Sharik?
I think this is a very good idea to make the thing more organized. And as we progress with our future meeting, the things will get more organized and more channelized, and it will be better for the future meetings. Thank you,
Thank
Dr.
you, everyone. Dr. Sharik, please go ahead.
Thank you, Dr. Sardar, for his valuable input. We are very grateful for your input and for your valuable time. I know you are very busy. And Dr. Hina for organizing everything and bringing difficult cases for discussion. And all the presenters, they have done a wonderful job. And inshallah, we will see you next month with a slight change format. Thank you, everyone.
Thank you. Thank you.
Thank you. Bye-bye.
Thank you, Dr. Sadar. Bye-bye.
Thank you, Dr.
Thank you,
Sardar.
everyone.